there's been quite a lot of work done in the palliative care world from that perspective. So in relation to things like spiritual distress in terminally ill patient or dying patients. And that's another part of my research area is we've developed a questionnaire, for example, to see if not just clinicians, but auxiliary staff who are on the wards, do they recognize spiritual distress in patients who are dying? And the answer is they recognize the definitions, but they don't recognize the behaviors.
Welcome to FC2O. Today we have Phil Austin with us, an osteopath, researcher, and author of the book Chronic Pain, a Resource for Effective Manual Therapy. In this episode, Phil and I delve into the importance of a holistic and integrated view of working with people experiencing persistent pain or ongoing health challenges. So settle in with a cup of tea and dive deep with us into topics as diverse as irritable bowel syndrome, the Virgin Mary, psilocybin mushrooms, and virtual reality. Enjoy the show. Here we go.
So, welcome to another edition of FC2O with me, Matt Wallden, and my guest today, Phil Austin. Welcome, Phil.
Hi, good to be here. Thanks for asking me.
Yeah, no, that's a pleasure. That's a pleasure. So, Phil, obviously, I know your background is as an osteopath from the UK, so we've got a lot of common ground there. So, where did you train for your osteopathic training?
I trained at the European School of Osteopathy.
Oh, okay. And between which years?
93 and 97.
Exactly the same. So we've got a mirror image there. I was at BCNO as it was then, and of course it's BCom now. But okay, that was so we could have ended up in the same class. So what was it that made you?
I wanted to go to BCNO, but I couldn't get a grant. I couldn't get a grant for ESO. But don't tell me.
Really? Okay, yeah, it was interesting. Actually, I wanted to go to BSO because that was mainly because that was the one I was familiar with.
Yeah.
And then obviously went to the other colleges to take a look, and I actually preferred the other two. I love the idea of being in the countryside with the ESO, but the BCNO somehow captured my imagination more, and so I ended up going there. But yeah, so you did that training, and then what do you do post graduation?
I got a job in the west of Auckland in New Zealand, and I moved out there about a month after I graduated.
Wow! So I did almost exactly the same. So I was in Rotorua, so I was a couple of hours south of you.
Yeah,
and probably a little bit smellier as well. Yeah. How was it in your part of the country there? Did you have much volcanic activity, or was it generally?
I was near the beaches, so it was. I worked in a practice run by a girl called at the time Helena Bromley, which is she's now Helena Towner, and she's still there.
Right.
And it was a really sort of busy village practice on the outskirts of Auckland.
Fantastic, excellent. And how long did you stay in New Zealand?
I was there for a couple of years.
Yeah. Okay. And then did you come back to the UK, or did you? Because you're in Australia now, aren't you?
Yeah, I came back to the UK and I was there from 99 to 2006. Right. And then I moved to Sweden, did a few years in Sweden, and then I came here to Australia.
Okay, because I knew there was a connection with Sweden, because one time when we were trying to set this up, you were saying that you were in Sweden. Were you teaching, or were you just visiting?
No, I was just on holiday, just visiting friends.
Oh, okay, excellent. I wondered what the connection was there. Okay, fantastic. Well, I also go to Sweden from time to time. That's mainly with my Czech teaching, but I tend to go to the south, to Malmo, or to just trying to think of where Aleko are based, Halmstad. Whereabouts do you tend to go to?
I was in Stockholm.
Yeah. Okay.
I did a bit of work in Gothenburg at their college quite often.
Yeah.
And I was living
really?
there.
Yeah. Okay. So when did you do your PhD?
So I did. I'll start from a bit further back. I started a master's at Edinburgh University in pain management.
Right.
In about 2007.
Yeah.
And then, and on the back of that, I did a research study for the master's program, and that sort of naturally led on to the question that was being asked was then became the PhD.
Okay.
And started that in 2010 and finished in 2015.
Right. Okay, fantastic. And so, what was the sort of theme of the PhD? What was that question?
Well, the question at the beginning was for the master's program was looking at multidimensional diagnostic algorithms, if you like, for chronic visceral pain.
Okay.
And I think, like all osteopaths, we're all a bit frustrated with chronic visceral pain. It's very hard to treat because there's so many different comorbid factors, as it were. And it turned out at the time there was no multidimensional or multi-axial diagnostic criteria for any of the functional GI disorders, really. So my PhD was quite a large Delphi study targeting worldwide experts in functional gastrointestinal disorders.
Yeah.
And I put out quite a few questions to them, and on the back of that led to the development of what's called the Rome Foundation's Rome 4 criteria, which then became a multi-dimensional diagnostic criteria for things like irritable bowel syndrome, functional dyspepsia, all the pediatric chronic pain syndromes as well.
Right. So I guess IBS is probably the best known of the functional GI disorders.
It's by far the most common, for sure, yeah.
Yeah. And what was the dyspepsia one?
Functional dyspepsia, that's a sort of functional reflux.
Yeah. Okay. And so, where did that research end up leading you? So was the visceral side of it really
Well, it got taken out of my hands, really, because once my PhD had finished and I'd published the articles on the back of that was then swallowed up by the Rome Foundation, who were taking on that project anyway.
Right.
And it's a project for over 100 people in reality. Mm-hmm. So I sort of left it at that, really, and then I moved to Sydney and I took on a research role there, initially looking at visceral pain, but then moving on to other stuff.
Right. Okay. And so this Rome Foundation, that they are still sort of continuing the work that you did, and so what have they created that's useful from a clinical standpoint for us in practice? Is there something that you would say, you need to go to this resource for questionnaires or for learning or whatever? What can we?
Well, it's exactly that. It's a source of questionnaires and it's a source of learning. They publish not only journal articles but books. Right. And I mean, it's not a free service. You have to pay.
Okay.
Per questionnaire or for the whole lot of questionnaires. I mean, there's over 60 different types of functional GI disorders, so there's quite a lot of information there. But if you go to Google and put in the Rome Foundation, all the information's on the website.
Yeah, and presumably that's spelt as in the city.
Yeah.
Is it? Yeah. Good. So I guess if we've got clinicians listening to this, or people working with anyone that may have functional GI disorders, or even members of the public who think that they may have something going on with their digestive system, and it hasn't been diagnosed, what is the I guess what's the practical sort of application of this Rome Foundation? Could they go online and find the right questionnaires for their patients, or is it a case that they really need to find someone like you who can advise?
Yeah, they could go online and order, or there might be some.
Yeah.
There might be some free stuff if you go on to sort of Google Images. You get the occasional questionnaire on there as well. I mean, it's really symptom based because there are no gold standard diagnostic tests, as it were, and because there's so many different sort of confounding factors or comorbid factors. This is the whole point of these. Well, it's not just chronic visceral pain, but any chronic pain disorder. It's the net result of many different inputs, most of them being negative.
Yeah. Sure. And so then, if we're trying to explain what that does to someone, let's say we've got a patient come in, they've got these digestive symptoms. Maybe they've even found a questionnaire that's diagnosed or sort of. That's actually quite an interesting point. Are the questionnaires able to just facilitate a diagnosis, or are they quite diagnostic in themselves? Like, how accurate are
Well, they'll be diagnostic in themselves for a set of symptoms.
they? Right.
So it's a bit similar
Yes.
to the fibromyalgia diagnoses where the old ones, where if you have 11 or more points out of 18,
Yeah.
painful points, then that is a symptomatic diagnosis of fibromyalgia. I mean, that's a bit old-fashioned.
Right. Yeah.
But for example, if you have all of these symptoms, let's say it's for the purposes of today's discussion, irritable bowel syndrome, you have your abdominal bloating, distension, sensation of fullness, flatulence, constipation, diarrhea, and you've had all of your medical tests and everything is negative. It'd be quite easy to go to an osteopath or any form of therapist, and they can work biomechanically. But because the inputs are very rarely biomechanical, this is where the confounding factors and the comorbid disorders come into play.
Yes. Yeah. Okay. And so then let's staying with that. Let's say it is an osteopath or someone who's working with more mechanical approaches. What would you encourage those practitioners to then do? Do they need to team up with someone who is a nutritionist or a psychologist or psychiatrist? Or
Absolutely.
Yeah. Okay. And so, what would be? Have you got any case examples, or could we create a kind of hypothetical example of someone they've come in, perhaps they're testing as having irritable bowel syndrome on one of these questionnaires, and like you say, there may be a small mechanical input, perhaps. I don't know if you still subscribe to that, but probably there's a lot more biochemical, emotional, lifestyle factors that are driving it.
Absolutely.
So, how might you deal with someone like that?
Well, I mean, sometimes it's in your control and sometimes it's out of your control. Right. So the most common example would be, I mean, if anyone who works in the centre of London or any capital city in a finance area or an area of law, they're under the pump for the majority of their younger working lives, usually unable to meet deadlines, and they become quite stressed and they don't sleep properly and a whole load of other sort of issues as well. And because of that, their diet tends to go down the pan, and the net result of that is these irritable bowel symptoms. Now, it's very easy for you to say change your job or change your lifestyle, but in reality, it's what they've spent years going to college for, and it's the job that they've signed up for, and it's very difficult for them to challenge the deadlines that are given to them, if you see what I mean. So it's very difficult for you to have an influence on those types of people. And they're more your sort of maintenance type people. So you work on the factors that you can affect, things like sleep, things like diet. You can obviously work on sort of more musculoskeletal, spinal factors that you think might be influencing these irritable bowel symptoms as well. How effective you are with that is probably impossible to sort of find, really. It'll be temporary at least.
You see, one of the things that sort of reminds me, when I did my master's degree in 98 to 2000, we had a section in our master's degree taught by Caroline Stone, who I love.
Oh, yeah.
Brilliant teacher.
Know very well.
Yeah, of course. And she is very much, the visceral specialist, one of the key visceral specialists in the world of osteopathy. And she, at that point, so I don't know if she's changed her mind now, and she may well have done, but at that point, I remember saying to her something along the lines of, do you ever work with nutrition with your clients? Because, of course, she's, teaching a lot about, let's say, bowel dysfunction or whatever. And she said, oh, no, I like to see what osteopathy can do on its own. I don't want to kind of cloud it by using other modalities. And in a way that disappointed me, because that's, I've been trained obviously at BCNO. So we were very much taught about nutrition and about psychology and the impact of those sorts of things in addition to the mechanics. And obviously what you're saying there is that really, for something like IBS, as much as there may be some benefit from a mechanical approach, there's so many other factors that have to be addressed. And do you think? Well, I don't want to sort of cast any aspersions.
No, I don't mind.
but
I don't mind.
Do you think that's the way that most people should be beginning to think now, and perhaps Caroline's thinking that way as well? by now.
I think most people are now thinking that way. Most people are, even if they're just thinking about it, have a sort of now more related to the concept of a biopsychosocial approach to most chronic painful disorders or conditions, whatever you want to call them.
Yeah.
And whether that's, if you take on all of those hats, then that's fine, as long as you're prepared to sort of see it through, if you like.
Yeah.
Myself, I've always worked in multidisciplinary clinics, so I work with psychologists, I work with nutritionists, I work with acupuncturists.
Yeah.
So we tend to cross-refer quite a lot.
Good. And does that work quite well?
Depending on what's going on.
It can be, I've experienced sort of multidisciplinary clinics in the past, and some of them work better and some of them don't work so well. It's almost like it's a series of individuals that provide a breadth of treatment, but they don't necessarily inter-refer.
Well, that's exactly right. So, but that's a difference. A multidisciplinary clinic, they may not ever talk to each other. So I would rephrase that and say interdisciplinary.
Yes, exactly. Yeah. Now, I was talking with a colleague of mine who runs an interdisciplinary clinic in London, and he corrected me on that point as well. so yeah, that's good.
And it's very easy to think that you are following a biopsychosocial model as a monotherapist, if you like. But whether you actually implement your thoughts into practice. I mean, one of the things that I've been doing in the research is I hand out a lot of questionnaires to participants. So cognitive stuff like catastrophizing and hypervigilance and the likes, but also emotional-based questionnaires, moods, stress, depression, anxiety.
Yeah.
And even to the point where we ask about people's meaning and purpose in life and relationships and faith, not necessarily in a higher being, but in their GP, for example.
Right, yeah.
And you can really see in some of the papers we've published, we can see what the predictors are for people who get better and people who don't get better. So, for example, people who catastrophize a lot, i.e. they think the pain is never going to end, they ruminate constantly about what's happening, they're the most difficult cohort of patients really to get better, because they never stop thinking about it, they never switch off.
Yeah.
At the same time, people who have no meaning and purpose in life, they have no reason to get up in the morning, they're actually more predictive in not getting better.
Really?
So what we do on our pain program, and the sort of research arm of that pain program, if you like, is we've developed a meaning and purpose and inner strength resilience type approach to these courses.
Yeah.
So when we finished with them after 6 weeks, they've got tools to go off and manage themselves, if you like.
Yeah, fantastic. And can you?
It's really amazing.
Can you elaborate on that at all in terms of is there a defined process, or is it quite variable depending on the individual?
Well, these are group classes. So it's normally of a group of about 10.
Yeah.
And this is just unique to our clinic, and we have 3 pain specialist consultants. We have a psychologist, a physiotherapist, and I'm the guy who tortures them to get data, basically. And one of the main strengths are people meeting other like-minded or other people in the same situation as them.
Yeah.
Where they are not lost, and they develop friendships.
Yeah.
Over time of the course, and they remain friends. And one of the things that we found quite strange was that we were part of a service that covers the whole of Australia and New Zealand, and all of the data that we get from the pain program goes into a big data bank at Wollongong University,
right.
And they publish every year how everyone's doing, and we did really well because of the uniqueness of our course about the meaning and purpose and the sort of existential side of it, as well as all of the sort of physical and psychological side of things.
Right. Excellent.
And a couple of years ago, we had the distinction of having the best results of getting people off opioids, long-term, heavy-duty opioids.
Oh, wow. That's fantastic.
Yeah, over 50% had over 50% reduction in opioid use.
Wow. So that's fantastic. And so is that... are your methods being sort of expanded out to other groups? Is it something that you published on? Yeah.
So, I mean, I'm not in this particular study, but my boss, who's Professor Philip Siddle, who was pretty big in the International Association of Study Pain world, he And the physio have got a $2 million grant to develop a program that specializes in inner core strength, not being Pilates, but more resilient, more of a resilient-based core. And this has been our problem. What do we call a course? Every time we call it inner core strength, people think of Pilates.
Yes, exactly.
And we can't find a better name, unfortunately.
Yeah.
We've tried hours and hours. We've done all sorts of face-to-face meetings, and we're stuck with inner core strength.
Right. Fair enough.
But it seems to be the way forwards.
Yeah, for sure. Isn't it absolutely fascinating how powerful the mind is? Because all of those things you've just mentioned, talking about catastrophizing, purpose, meaning, faith, various cognitive assessments and emotions and so on. Obviously, that's a reflection of the individual's mind and mental state, I guess, which is obviously is then a reflection of their life experiences and the society they're within and so on.
But you can see if you can. These questionnaires are all freely available on the internet.
Are they?
And so what I do with patients who are particularly difficult, I'll give them 3 or 4 questionnaires after the initial consultation. They'll go away and do them themselves.
Yeah.
And then when they come back to the clinic, we'll see where their spike, where their high scores are.
Sure.
And then we'll work on those together. So if they think that every time they do any exercise or every time they get pain, it's a sign of tissue damage.
Yeah.
And they've been imaged to the max and there's nothing there, then once you tell them that it's actually not a sign of tissue damage, it's and you give them a basic pain education course on central sensitization.
Yeah.
They go away and they can really crack on and help themselves.
I think you touched on something there also that I guess historically there's been, and probably absolutely still today, there's a risk that when you start talking in those terms, that the patient thinks that you're saying it's all in their heads, which I know is a big thing that we need to be really careful with. So how would you convey that to?
Well, I'll start with the dorsal horn. So I just talk about things that didn't used to be painful and now are painful, and that is because inputs from the periphery haven't changed so much. It's the activity, the synapse in the dorsal horn that's changed.
Yes, exactly.
And that sends abhorrent or increased nociceptive or pain information into the brain, and it's perceived as being worse than it actually is.
Sure. So very simple terms.
But it's quite difficult to get the phraseology right. I mean, basic pain education is quite difficult to develop, to keep it in a sort of lay speak, if you know what I mean.
Yeah, absolutely, yeah. And so, what's your feelings on things like Explain Pain as a resource? Do you use that at all, or things?
I think it's fantastic.
Yeah.
I think. And that's what's his name, isn't it? Lorimer Moseley and the like.
Yes, exactly. Yeah. Okay.
I mean, they're more of a brain only. Nearly everything they talk about is from the brain.
Okay. Yeah.
But our lab tend to think that there still is some form of peripheral input that can kick everything off or can maintain. So we work on both sides, if you like.
Excellent. Yeah, that's great.
So we've just developed a questionnaire that's just been submitted after about 4 years of work.
Right.
And we're trying to elicit in this questionnaire whether pain is being driven from the spinal cord or the periphery or the brain down. And that will really sort of siphon management of that person a lot more quickly.
Right. And so is that about to be published in a paper, or how does questionnaire development work?
I mean, the trouble is it's quite a contentious area.
Yeah.
Because we're using everything's hypothetical.
Yes, of course.
Because what central sensitization is, it's a description of a series of altered morphological changes in the dorsal horn in animals, in animal studies, and we are hypothetically linking it to humans,
right.
who display similar symptoms that have been found in animal studies.
Yeah,
and that's the problem we have. So we've had a few problems in that we're basing all of our questionnaire items on hypotheses, basically.
Yeah, of course. And I suppose
reviewers and journal reviewers have their own opinions, of course, on lots of different things.
Yes,
and even the tests that we do. So we're using something called conditioned pain modulation. Which is a pain inhibits pain paradigm.
Oh, okay.
So if you have a test stimulus, for example, where you have pressure on your foot, and when you get to 4 out of 10, you tell them to come off, and you record the pressure pressed for that 4 out of 10.
Yeah.
In someone with no pain, if you then stick their hand in a bucket of cold water at about 10 degrees for a minute, and then you redo that pressure test, they will be able to stand more pressure for that 4 out of 10.
Yes. Okay.
That is essentially conditioned pain modulation. Now, in people with chronic pain, it's usually reversed, where their tolerance for the pressure will go down. So at 4 out of 10 will come a lot quicker.
And could that?
But there's a lot of argument about the actual test.
Yeah.
But that's one of the tests we've hung our hat on.
Right. Yeah. Okay. And could that in some ways explain some of the perceived benefits of hydrotherapy, or not?
No, not necessarily, because it could be any secondary stimulus.
Yeah. Okay.
It's just a conditioning pain stimulus. It just so happens that the cold water is the most reliable.
Right. Oh, that's interesting, isn't it? Is that because pain and temperature are sort of perceived via the spinothalamic tract?
Spinothalamic tract.
Yeah.
But you could also give them an electric shock.
Right. Yeah.
That's another way of doing it. Or heat.
Okay. Yeah. Interesting. So you mentioned a number of questionnaires, and obviously you know we've just most recently talked about the one you're in development with at the moment. Is the idea with that, will it ultimately be available to clinicians, or is it something that they have to pay for access to it?
No. It'll be available. It'll be freely available.
Right.
But we have to get it published first.
Yeah. Okay. And
otherwise, it won't be valid.
Yes, exactly. Yeah. No, fair enough. And the other question is, obviously, you mentioned that you give a raft of questionnaires, which I'm a huge fan of, actually, in terms of working with clients in that way. I think, the traditional way of the sort of meet and greet and making the assessment on the spot, I guess that can work to some degree for more acute conditions. But when you're dealing with people with more persistent health issues and pain issues, and I think the questionnaires provide so much insight that it's invaluable, really, to get started, or I should say, before you get started, have those questionnaires sent out. So, what's your process? Do you if someone calls you up and says, "Look, I've had X number of surgeries on my back or my knee or whatever it is, and I've been in pain for 10 years and so on," would you just say, "Okay, great, come in and see me," and then provide questionnaires, or do you send them out some questionnaires in advance?
I would speak to them first.
Yeah. Okay.
Whether we'd have a written consultation first.
Okay. And then, so what if it turns out that they were going through a difficult time with their business or their marriage, or they have bereavements around, that seem to mix in with the whole sort of etiological matrix, if you like, what would your thought processes be? Would you think this questionnaire is the right one, or we need to give them X number? So can you elaborate on that a bit?
So, I mean, you're really looking for cues. So if we start with something like mood, if someone describes their pain, well, if I go back even further, if someone describes their pain as being intense, it's really sort of sharp, and it's a sort of 7 or 8 out of 10. That's a sort of sensory cortex, character, location, and there's no other sort of factors that influence that. That's your basic pain response.
Right.
But that's an acute pain response.
Yeah.
But if someone says that their pain feels really awful or unpleasant,
right,
those descriptors are emotionally based.
Yeah, right.
And as soon as someone starts using those definitions of pain, then there's a good chance that there'll be an emotional component to their presentation.
Right. Okay.
So that's the mood sort of part of it, and those are the sort of basic cues. If someone talks about tissue damage and their vigilance, and they notice every single change in pain intensity and character, then we're talking about hypervigilance. If they start talking about the pain will never end and they can't see any hope, then that tends to be more the catastrophizing sort of areas. So unfortunately, you have to there's quite a lot of knowledge involved that you have to retain yourself as a practitioner to acknowledge what those cues actually mean.
Yeah, absolutely. Okay.
And that basically means you need to know what the questionnaires mean.
Yes.
And you need to know every single item, basically.
Yeah. Okay. And is there training for this? Is there, are there papers that you recommend or books?
Well, I mean, every single questionnaire will have had a validatory process
Yeah.
where papers have been published and how the items have been developed, whether they use item response theory or whether they use factor analysis, and which is all quite sort of theoretical and quite difficult to understand, I find.
Right. Yeah.
Then, yeah, it's quite. I mean, we've got someone, thank God, who's a statistician who's a bit of a whiz with factor analysis.
Right.
And all I do is crunch the numbers, but it's you just have to be aware of what catastrophizing, what altered cognition means in regards to pain, what altered moods means in regards to pain, and you can go from the sort of mood, cognitive stuff, and you've got to be careful that you're not crossing over into sort of more DSM, sort of personality stuff as well, because that's another problem.
Yeah. And so I know what you mean when you say that, but to clarify, essentially you're kind of saying that you don't sort of step outside your own area of expertise, and DSM is the Diagnostic Statistical Manual for psychological issues, isn't it? And so I guess that is difficult to know where that line is, because it's probably quite a fuzzy line, isn't it?
Well, again, there's people who, again, these are very generalized, so please don't hang your hat on these, but it helped me. If people who come in are anxious and distressed about their pain, and they try hard to get better, and they don't blame you and probably blame themselves, I didn't have a good night's sleep, or I've got deadlines at work, or the kids were playing up. That is sort of safe country, if you like, where people who have these mood sort of disorders, if you like. But people who start to blame you as a practitioner and never blame themselves for themselves not getting better, then you've got to start thinking, oh, this is probably out of my hands a bit.
Yeah, right. Okay.
It's more the personality stuff that's more apparent.
Well, I think that's...
Again, it's a generalized switch, but it works for me.
Yeah.
And I'm safe.
Yeah, for sure. I think that's a really fascinating area because, for me personally, I think that links back in very beautifully to the biopsychosocial model, from the perspective that, I've written about this a little bit in my editorials for the Journal of Bodywork and Movement Therapies.
I saw that.
Oh, did you? Okay.
Yeah.
But the idea that, from a social perspective, of course, we're growing up in societies that have, when I say we, I should say that but I imagine a lot of people, let's say from the UK originally, are growing up in a society that has a traditional religious belief of Christianity. And, of course, I want to be as inclusive as I can. So, whichever society you're from, there are no real societies without some kind of religious backdrop to them. We know that from the anthropological research. So, but the interesting thing is, when you look at the history of religion, religion has gone from being sort of more animistic, where you see spirit in everything from rocks to rivers to animals to trees, etc., to being more polytheistic. So, a god of war and a god of rain and a god of this and a god of that, to monotheistic, where you've got this kind of god in the sky. And it strikes me that what that does is it puts the idea of power, the locus of power, outside of the individual from a social context.
It doesn't. Yeah, I mean that's something that we work on again on the pain program. It's another factor.
Yes. And so I suppose where I'm really interested in your expertise on this is that, one of the things that we were trying to convey in the original sort of Ghost in the Machine paper that we wrote was that a lot of these beliefs are below the level of conscious awareness. So they're not the sort of thing that are easily identifiable through a questionnaire.
But they're not even identifiable by the person.
Yes, exactly. Yes.
Yeah.
So have you got any thoughts on that? Do you know if there's any work being done on that, or?
Well, there's been quite a lot of work done in the palliative care world.
Yes. Yeah.
from that perspective. So, in relation to things like spiritual distress,
Right.
in terminally ill patient or dying patients, and that's another part of my research area. Is we've developed a questionnaire, for example, to see if not just clinicians but auxiliary staff who are on the wards, do they recognise spiritual distress in patients who are dying? And the answer is they recognise the definitions, but they don't recognise the behaviours.
Yeah, right. Well, that's fascinating, isn't it?
Yeah, it's fascinating. And then a knock on from there was if you're looking at something like death anxiety, and there are actually quite a few questionnaires that measure levels of death anxiety.
Yeah.
People who are high, and a study we did in New Zealand that people who are highly religious have massively high levels of death anxiety.
Oh, really? Well,
compared to people who are spiritual, who don't follow a set of rules, who may be their existentialism is related more to sort of nature or whatever.
Yeah.
They have the least amount of death anxiety.
Wow, that's really interesting.
So the more rules you have to follow, the more stressful it is to keep adherent to them.
Right. I remember listening to a guy. I don't know if you've heard of him, called James Hollis, and he's a kind of. Do you know his work or not?
I know the name, but I might be familiar with his work.
Yeah. Well, he's more of a Jungian psychologist, I'd say. Certainly, he's got a strong Jungian influence. But one of the things that he says is that what is it? Religion is for people who don't want to go to hell, and spirituality is for people who have been there. Right, which is, I think, it's kind of.
I've never heard that, but that's quite interesting.
Isn't that? Yeah, I was just thinking in the context of what you were saying that. It's like there's this kind of fear of death, which I guess for some people is their sense of hell. But the idea that spirituality is something very, very distinct from that, and it's a means of coping with our existential anxieties, and perhaps people have been bereaved or who have had very traumatic situations, and they have to try and make sense. It's like a sense-making mechanism of the world, and so you can see how that could reduce stress. But kind of back to the blame side of it. If you've got the idea that the locus of power is outside of you and it's in a god that's in the sky or whatever, and yet he or she or whoever you perceive God to be is not helping you with your pain, then you can understand that this blame culture or sort of psychology starts to ramp up in you. It's very, very fascinating. And like I say, it strikes me it's not just a psychological thing, but it's a social thing. And that there's this kind of almost, this is why we called it the ghost in the machine, is that, we were talking about the ghosts from the perspective that it's unconscious or you're unaware of it, but also the fact that it kind of almost seems to transcend generations. And it's almost like a hidden factor in our behaviors is the fact that we have come from certain cultures that have certain beliefs. And, one of the studies we talked about, go on. Let me just finish this a moment, and then I'll come back to you and your point. But one of the studies that we talked about was a study which was looking at. It was called foxhole atheism, and it's the idea that when you are you take two groups of people, and you've got one group that are via questionnaire again, they're assessed as being atheists, and another group that are assessed as being non-atheists, not necessarily religious, but non-atheists. They believe in a higher power. Then when you ask them consciously in a questionnaire about their spirituality and their belief in a supernatural or a higher power of some sort, then of course you get exactly the response you'd expect. But when you prime them implicitly to think about death and then retest them and only give them a very short period to respond, what you find is that the atheists all switch to becoming much more believers in some kind of spiritual afterlife or so on. So I just found that they were saying there's no such thing as an atheist in a foxhole, which is fairly sort of well-known comment relating to the idea that if your back's against the wall and you're facing death, then most people actually do innately have some kind of deep spiritual longing or feeling, etc. So
protector.
What's that, sorry?
or a protector.
Well, yes, exactly. Yeah. Sorry, I know you were going to jump in at one point there. Did I throw you off your
No, absolutely not. I mean, if you want, there was quite an interesting study done at Oxford by a woman called Irene Tracy,
Right.
who's quite famous in the neuroscience world, especially regarding sort of pain mechanisms and pain pathways.
Yeah.
And she did a study with Catholics
Mm-hmm.
where she showed them as the test the image of the Virgin Mary,
Yeah.
and then as a control the image of a woman who looked very similar,
Right.
but was not the Virgin Mary. And at the same time, they did a lot of functional imaging, MRI imaging of brain responses. And at the same time that they gave them showed them the images, they also gave them a painful stimuli, which was an electric. I can't remember what it was, but it was a nociceptive input anyway. That was painful. And when the Catholics looked at the Virgin Mary, the pain responses were a lot lower than when they showed them the picture of the equally nice looking woman, but even though the pain stimulus was of the same intensity.
Wow.
And when they did the functional imaging, they found that an area of the prefrontal cortex, which is the area which is where you sort of process all the information that's sort of been thrown into the brain, as it were. There was a specific part of that prefrontal cortex that lit up when they were shown of the Virgin Mary, but it didn't light up when the other image was shown, which is quite interesting. So it is almost innate.
Yeah. Like there's some module in the brain.
Yeah.
That
if only you could find it and use and manipulate it.
And would that relate to? So one of the people I've been interested in reading around his work is a guy called Philip Zimbardo. His whole sort of latter part of his career has been based around time perspective and looking at people's. There's essentially 6 different time perspectives. So there's as he's defined it, and he's tested his various. He calls it time perspective inventory, and basically there's past positive and past negative. So this is how you view the past, and what recollections you have of it. Then you've got present hedonistic or hedonistic and present fatalistic. And then you've got future, just a sort of general future time perspective, and then you've got transcendental future time perspective. And it strikes me that what you were saying there about the functional magnetic resonance imaging of people looking at the Virgin Mary, it's almost like they probably have a very strong transcendental future time perspective. They're looking to this kind of post-death figure that is there for them in the afterlife or whatever, and that somehow that's providing some kind of sense of security to them in the present.
Yeah, absolutely.
Yeah. It's because one of the things that Zimbardo talks about is that it's very important to get the balance right between each of these different perspectives. And if you focus too much on negativity in the past, then that's going to potentially hold you back and make you keep ruminating on those past life events that didn't serve you well. And of course, if you focus too much on the future, then you're not present in the now. And so, I guess it'd be really interesting. And I know that he's done a lot of research with different religions as well, and religious groups. But it'd be very interesting to understand more about the time perspective profile and how that affects people in pain.
Well, I mean, epidemiologically, there are answers to those sorts of questions.
Right.
So, for example, you talk about people looking negatively in the past.
Yes.
And most people with chronic pain have had some form of negativity or adverse event or events in their childhood or in their teens. And so, for example, I think a study was done in the mid-2000s, but people who had 3 or 4 early life adversities, i.e. during neuroendocrine development, they were more or less guaranteed of an adult onset chronic disease.
Wow.
So what happens there is that if you give a child who is developing a consistent or a set of highly anxious situations,
Mm-hmm.
And it doesn't have to be anything dramatic like the worst forms of abuse, but it could be maternal-paternal separation, for example.
Right. Yeah.
That will have quite profound effects on the sort of hypothalamic pituitary adrenal axis.
Yes. Yeah.
It'll set up a higher state of inflammatory product release generally on a permanent basis.
Mm-hmm.
And because of that, you are more susceptible to painful situations because you're already producing a larger amount of inflammatory product than you would be normally.
Yeah.
And that's because of this heightened hypothalamic pituitary adrenal axis.
Right. Yeah, and I guess so. An example that I've heard before is it's like turning up the gain in a kind of speaker system, so that
Yeah, exactly.
When you strike that guitar string, suddenly everything goes blam, and that's the kind of example of someone who's experienced, like you say, a significant life stressor early in life. Whereas for someone who hasn't, then you hit that guitar string and it's set at the right level, and it just it might be uncomfortable, but it's not going to go into kind of sensitized mode. Is that fair?
Yeah, that's fair. But the other unfortunate thing with all this is that the feedback mechanisms, because of this release of inflammatory neurotransmitters and other sort of hormones released from the adrenal glands and the pituitary gland, they have negative effects on neurotransmitters in the brain, which are essential for development, for example, in children.
Right.
So this is why the kids have developmental problems as well, and it's not because of the way they were born, but the feedback mechanisms that have occurred as a result of repetitive stressful events, if you like.
Yeah, of course. Have you ever seen much of Bruce Lipton's work and his sort of description of, I guess, epigenetic expression?
Well, that's exactly what that is.
Yeah.
It's because you are changing, you are developing a new phenotype
Right.
with these events.
Yeah.
So once you have this cranking up of the volume, if you like, that it might go down, but it will never go down to what it should be, because you have morphologically changed synaptic strength in some areas and you've basically increased synaptic strength in facilitatory areas and decreased synaptic strength in inhibitory regions or pathways, if you like.
Right. Yeah.
And so that could relate to the dorsal horn, inputs coming in from skin or muscle. There are a new type of supercharged receptor in the synapse that reacts more easily to sort of insignificant input, if you like.
Right.
And those are new phenotypically produced receptors that won't go away.
Really.
Greater concentrations of these receptors are produced than before as well. So you get a larger concentration, which it makes it more able to produce stronger inputs going up to the brain. So that's just the dorsal horn.
Yeah. Wow.
Then you've got all the other areas of the brain as well which are involved, and the descending inhibitory pathways, which are involved in the conditioned pain modulation I was talking about earlier.
Yeah. So essentially, for those.
So epigenetics is a huge part of.
Sorry. I think there's a slight delay there. I was just going to say that for people that are unfamiliar with what we're talking about here, I guess the simple way to say it is that your pain threshold has decreased, and your pain perception has increased. Is that they're the kind of two arms of the same process, I suppose, which ultimately results in increased pain perception overall.
Absolutely. Yes. And also people with chronic pain, they have thickened areas of grey matter that are related to pain facilitation and atrophied areas of brain matter that are associated with pain inhibition.
Yeah, that's amazing, isn't it?
So going in as an osteopath thinking that you're going to do wonders with biomechanical input ain't going to do it justice, really.
It's not going to cut the mustard.
There needs to be other inputs.
Yeah. For sure. And so one of the things that I know that Bruce Lipton talks about is the fact that, we're talking about the individual and them having potentially, a major life stressor early in their lives during developmental years. He was talking even, when we're saying developmental, he was talking even with the child in the womb, when the mother is very stressed, then the release of cortisol into her system crosses the placental barrier, gets into the fetus, and redirects blood from the forebrain to the hindbrain. So you end up with a child who has a lot more of a reflexive kind of capacity as opposed to a responsive capacity. So they're more
Absolutely
likely to get, let's say, they may struggle more with ADHD type symptoms, or just be more kind of reactive and get into more trouble with their peers and so on. I know that sounds like a huge generalization. I'm sure it is a
No,
generalization.
it's not, because there's been a large amount of recent work done in Cork.
Okay.
Looking at the effect of stress on animals who are pregnant and how that affects the fetus.
Yeah.
And one of the biggest causes of this hyperreflexia, if you like, is down to alterations in gut bacteria.
Oh, really? Oh.
And bacteria can infiltrate the blood-brain barrier, especially at that age.
Yeah, of course.
Then facilitate everything that we've been talking about over the last 50 minutes.
Wow. That's incredible, isn't it? Who'd have thought that these little bacteria could have such an effect? Suddenly we're beginning to realize the importance of these little guys.
Well, it's looking like they're important in personality disorders. They're important in visual hypersensitivity. They're important in a whole host of different things. Dysbiotic microbiota, if you like, would be the correct term, I would say.
Yeah. Okay. Yeah. Very interesting. Now, so sort of taking this a step further, Mark Wallden is a guy who I was reading his book recently. His whole thing is looking at the core languages that we use, and essentially, I guess his hypothesis is that we inherit a certain way of talking about the world and communicating about the world through our family and through our tribe, if you like, people that we're exposed to. And so he's very interested in that. But his part of his research was looking into epigenetic effects, and he was quoting. So he was quoting other people's research. Particularly, there was a lot of research on Holocaust survivors showing markers of all kinds of HPA axis dysfunction, blood sugar dysregulation, and this seems to be true up to 3 to 4 generations beyond the Holocaust survivors. Now, is that anything that you've read into or have any background awareness of?
I don't have any background, I'm afraid.
No.
But I can totally. It does make sense, because once you change your phenotype, or parts of your system phenotypically, that will be passed on to the next generation.
Yeah. Very.
So it makes sense from a genetic perspective, of course.
Yeah. Very interesting. Yeah. Excellent. Okay, so looping back around to the visceral pain where we started off. When people let's reframe that to visceral. I don't know whether dysfunction is a good term, or visceral symptoms, because there's many people out there that would have, for example, let's say bloating, or they might have a bit of diarrhea, but they wouldn't particularly say that they're in pain, and they might not really. It doesn't really affect their lives particularly. So something like that, where you've got something fairly low grade, and then maybe a history of an old knee injury. So the knee injury is from time to time flares up and gives you a kind of pain input into the lumbar spine, sort of L3-4 level. You've got your colon, let's say, sending some afferent drives because it's a bit irritable into L2 sort of level, L1, L2. Would those two things together potentially be enough to make you somewhat sensitized and more prone to, let's say, a persistent low back pain? Or is that not enough? Do we need more than that?
No, again, it depends what the person's come in with. It depends what's there before, really.
Right.
Would be the answer to that. I mean, the other thing is that the segmental innervation thing that we've all followed with the stomach T6 to 10 liver T6 to 10.
Yeah.
It doesn't. I mean, that's sort of old news, really. I mean, most visceral organs are so multi-segmental they're indistinguishable from each other. So, for example, the stomach, or just the esophagus, can be has been recorded in animals as being going from T2 to L4, for example.
Wow, that's a big range.
So there's no real differentiation between levels,
Right.
and that's one of the reasons why visceral pain and visceral symptoms are really quite diffuse, really poorly localized.
Yeah.
And that's because once it goes into the spinal cord, it just goes crazy. It just goes all over the place. It doesn't just go up and down many segments.
Yeah.
I mean, if you compare it to a single somatic afferent neuron that comes into the outer part of the spinal cord, the dorsal horn, and it synapses in one laminae, and it has one connection and it goes to the brain. Hence, we can measure with dermatomal testing, if you like.
Yeah.
If you do a comparative single visceral afferent neuron coming in, it branches like crazy over many, many different laminae, and it also crosses over contralaterally or to the other side of the spinal cord as well. And it additionally goes into the dorsal horn as well. So we always think of the dorsal horn as being sort of like touch and proprioception and what have you. But there's a strong visceral pain component or pathway in the dorsal horn, in the dorsal columns as well. So it's a bit of a different beast. And there's also the influence, as we're finding out now, that has been driven mainly by altered composition of gut bacteria.
Yeah.
And it's not that I'm preaching the newfound fame of gut bacteria, but it's looking like, phenomenally, I would say, that gut bacteria are responsible for much more than we ever considered.
Yeah. Okay.
And it's not simply corrected with a bit of kimchi or whatever. It's quite a difficult thing to approach.
Yes, exactly. Well, interesting enough, I went to Mexico for my brother's wedding a couple of months back, and I picked up some kind of Mexican gut rot, and I was in trouble.
It's not wonderful.
Yeah, it was brilliant. I was in trouble for a couple of weeks after that just to stay hydrated. So I won't give you any more detail than that, but you could.
I've been there.
Yeah. But I thought, okay, I'll take some probiotics, and I was taking some, I forget, like some garlic and stuff. And after a few days, you think, this is just ridiculous. This stuff is so impotent compared to what's going on in my gut at the moment, and it's almost like you just have to ride it out. And I not to say I don't recommend those things or I wouldn't do those things, but it makes you realize the potency of these, just little infections.
Absolutely.
And how limited, like you say, a bit of kimchi is not gonna solve that problem.
Well, the results from studies are so varied. Some people, like, they'll have a fecal transplant and they're a changed person.
Oh, really? Okay,
it's
yeah.
phenomenal. But other people will have the same thing and it doesn't even touch them.
Yeah, I've got a client.
So the consensus now really is that the gut bacteria you come out of your developmental years with is the one you're going to keep.
Right. Yeah. And I've read also that it relates very closely to, of course, the company you keep. So your family, your tribe, the people that you hang out with, which is kind of interesting as well. That it's again, it's almost a biopsychosocial biome, if you like.
Well, it is. Absolutely.
Yeah.
Culture.
Yes, absolutely. Yeah. Funny that, isn't it? Funny how these terms overlap. I always, I remember the moment when I realised that the term the colon is called the colon because it has a colony of bacteria in it. It's like these little linguistic things that drop into your head. You're like, that's why it's called that, and that's how we make sense of these things. Okay, so one thing that you may or may not be aware, but it's something that it's been a kind of pet topic of mine, and I've worked with it a fair bit clinically, and seems to add up to me. But I'd be interested in your take on it. Is the idea that visceral pain or viscerosomatic reflexes can affect motor control potentially in the regions. Let's say, I know you just said that we can't really talk about topographical regions so much, but let's say if someone had a colon issue or had any kind of digestive issue, really, that may affect the functioning of the musculature in the core. And this is something that
I don't know anything about that, to be honest, but it sounds interesting.
Okay. Well, yeah. So I found research, and I don't know exactly the quality of it, but I've found obviously back in the day at college, Frank Willard was talking about this kind of
Yeah.
thing a lot. But I've subsequently looked into various other research papers, which I've written about in my editorials, which seem to suggest that when you get let's say aberrant afferent or sensory drives into the cord, and you get this sensitization starting to be set
Mm-hmm.
up, that it seems that there can be an inhibitory effect on the tonic motor neurons.
Yeah.
Just like with pain, when you get pain, we know that the tonic motor neurons seem to become inhibited to some degree by pain.
Yeah.
And so it strikes me that when you look at the whole sort of field of motor control, I haven't seen any studies so far, although I haven't looked in the last couple of years, but I haven't seen any studies that talk about visceral drives and whether or not they may be impacting, essentially quite a potentially significant confounding variable on motor control. Because as we've just talked about, a lot of people in pain have a whole raft of other
Yeah.
things. Let's say we just take a population of persistent low back pain patients, then a whole raft.
And you hit on an important point there, actually. In that one of the things that are really good for chronic functional GI disorders is exercise.
Right. Yes.
Exercise is shown to be far more beneficial than anything else.
Mm-hmm. Yeah. It's amazing.
What reflexes and what pathways they affect, we're not quite sure. We know that by doing exercise, you are being anti-inflammatory. You produce a whole lot of transmitters that reduce inflammatory mediation. You also produce a whole load of endorphins, and you produce endogenous opioids and what have you. But there may be other things that are in the mix as well that also can have inhibitory effects on visceral pain as well.
Yeah, for sure. Because when it just strikes me, I was looking at your chapter in your book on visceral pain, and on the first page, you're talking about the epidemiology of visceral pain. And
I haven't looked at the book for about 2 years, just so you know.
I bet that's all right. I'll read it out to you so it jogs your memory. But you had the visceral pain rates in adults, 25% for intermittent abdominal pain, 20% for chest pain, and 16 to 25% for pelvic pain in women. So it just shows you, this is essentially around a fifth to a quarter of the population have active pain in the visceral system, and that thereby potentially possibly lowers their motor control. That's my sort of hypothesis that I threw in there. But it certainly is. It could well be lowering their threshold for pain, so they perceive pain that bit earlier, and the pain persists that bit longer because of that underlying visceral issue. Does that make sense to your way of thinking?
I mean, I think there's probably a few more factors involved.
Yes.
Which may be numerous, but I would say essentially, yes.
Yeah. Fantastic. So back to talking about the sort of more spiritual factors research that you got involved in, because you've got a few papers on those that you've either written as the lead author or as a secondary author. What would you say you've taken from that research to your clinical work? Because it's quite, I often when I'm presenting, I do explain that I see myself as working with patients using a physical, emotional, mental, and spiritual model. And I always, and I know that's going to raise the eyebrows of some people in the audience always, because you're talking to a heterogeneous group, of course, with a whole array of beliefs and understandings. And but the way I temper it a little bit for everyone is I say, the important thing is that it really doesn't matter what you believe as the clinician, but it really does matter what the patient believes, and that's why you've got to have that. I believe you've got to look at an individual from a physical, emotional, mental, and spiritual perspective.
Well, I think you've got to acknowledge what they believe.
Right. Yes. Exactly. Okay.
I think you can do no more than that, really.
And so, what would your approach be from, if you had someone come in who was, let's say, a terminal cancer patient, and they were looking for, so maybe they heard that they might get some pain relief from working
Yeah.
with you, and so they've come in to see you, and you sort of thinking, okay, this person is clearly going to have some existential, or not clearly, but likely going to have some existential anxiety going on here. Have you got any specific tools you would go to in terms of assessment or in terms of approaches?
We use something called the Facet Extended Spiritual Questionnaire,
Facet Extended Spiritual Questionnaire.
which you can get on it. It's FACIT. They do a whole range of different questionnaires for chronic diseases.
Okay.
And the Extended Spiritual is a 23-item questionnaire that the first 8 items are related to peace and meaning. The second 4 related to faith, and the last lot are related to relationships. Right. And I tend to, I don't see terminally ill patients as a rule. Sure. I've questioned them in research studies, but I've never, which I find quite difficult, I have to say. So, once you work out where their spirituality lies or their emotion lies, you work on a sort of meaning-based concept, if you like, and you find out what they want, where they want to go. Even like we use virtual reality, you can just stick a Google Earth immersive VR headset on their heads, and a lot of them. There was a study that came out recently. Most people who are dying, they don't want to go back to where they live. They want to go to a place they've never been before. So you sort of open the door for them, if you like, and you give them the hint, and they can take it from there.
Right.
And then you empower them by doing that.
Yeah.
So it's also about empowering. We haven't really talked about that tonight, but empowering patients. It's no good you starting off as the clinician saying do this, do that, but you have to empower them enough to get them to do it.
Absolutely. Yeah, and I think that's so.
So I would say, I'm about patient empowerment. If that was my end goal, that's what it would be.
Yeah. Okay, brilliant. And so that questionnaire that you mentioned, what does that give you as a clinician?
It tells me. It depends which part of the questionnaire I'm looking at. I normally just look at the first 2 parts, to be honest.
Yeah.
But in a nutshell, if they've got no reason to get up in the morning, you've got to give them a reason to get up in the morning.
Yeah, for sure.
And if they don't have faith, and from a faith perspective, if they don't have faith in their GP, then you can advise to get a second opinion, something as simple as that.
Yeah.
Or you've got to work on them having faith in you as well, of course.
Yes, absolutely. Yeah. Interesting.
But the meaning part of this whole thing is for me is the most important.
Yeah. Okay. Good stuff.
You have to people have to have meaning in what they do.
Yeah.
And why they do it.
Yeah, for sure.
Well, whether they've got 3 days to live or 30 years to live.
Yes. Well, that leads into a couple of papers that I've read recently, because I guess for both my editorials, but also for some of the teaching that I do, we talk a lot in the Czech system about a process that we use called the 1, 2, 3, 4 approach, and so the idea is that with any patient or any client, let's say, because a lot of the people that a Czech professional would work with are not necessarily in pain, but they just have a performance goal, let's say. But even then, sometimes the performance goal may not be relevant for them given their physiological status, or it may be that they've perhaps developed a goal based on again a kind of social or cultural norm, and when they really dig down into why they want to achieve that goal, it may be actually that's not what they want to achieve with their life. And so what we do is we have a kind of coaching system where we help them to identify what their purpose is, or their what we call their one love. So that's the one dream or the one legacy that they're going to leave behind. So it's the big purpose for their life, And then the next phase, so the number 2, is looking at the balance of catabolic to anabolic stresses. So essentially the yin and the yang, if you like, of life. And to take using the questionnaire system that we have, we look to see, are they extremely stressed? Is their digestion good? How is their sleep, etc., etc.? Are they hydrated or dehydrated? So we use this whole sort of approach to say, well, of course, for most patients, people that are in pain, they tend to be a bit too yang. They're in a state of inflammation. Sometimes they're in a state of not sleeping enough. They're too stressed. So these are all kind of yang qualities, as opposed to being rested and relaxed and well fed and all this kind of thing. So it's just, again, you can coach them on that and say, well, where do you think your life is out of balance here? Are you too yin or too yang, too catabolic, too anabolic? And
well, I guess we do that in practice, really, anyway, don't we? If we're taking a biopsychosocial approach, anyway.
Yes, absolutely. But I suppose where I was going to go with that was that the papers that I found, one of them was saying that it was looking at longevity in the over 60s. And it was saying that people who have purpose have greater longevity by a very strong statistical margin.
Oh, absolutely.
To those who don't.
Absolutely.
And that's not that surprising. You could say it's common sense, but and it's also, I guess, a common observation, isn't it, that when people retire, there's a real period in the first, I think, year or two after retirement that the mortality rate really shoots up. And when you get through a certain period post-retirement, then you tend to last a bit longer if you can develop that sense of purpose again. But the other thing that struck me, which ties back in with a lot of your work, is that I had another paper that I referenced, which looks at purpose as a predictor of allostatic load. And for me, so what it was showing was that if you have life purpose, and they measure you for allostatic load, at the moment the trial started, they then reassessed 10 years later, and 10 years down the line, what they found was that the people with purpose had a much lower allostatic load or allostatic.
So how did they measure allostatic load in that case then?
They measured it. It was a whole raft of tests. A lot of things like assessing HbA1c, measuring. So that's for blood sugar, measuring cholesterol, measuring HPA axis function. So it was a whole raft of biochemical screenings as opposed to questionnaires. But what they found was that 10 years later, the group that had life purpose had a much lower allostatic load than the group that had no definable or defined purpose, let's say. So
and that's probably because they've got a greater. Yeah, go on.
Well, I was going to say that what that suggests is that the allostatic load is what, to me, is likely to lead into all of the symptoms that we've been talking about that perhaps are either clinical symptoms or subclinical symptoms that can cause central sensitization in the longer term. Yeah.
So I mean, so it's a sort of facilitatory loading is another way of looking. I mean, allostatic's quite a broad term. A lot of people use allostatic loading quite wantonly, I think.
Yeah.
But for me, it's an over facilitation of emotion and cognition, or altered cognition and dysbiotic microbiota and central sensitization relating to pain. It's a whole body facilitatory response.
Yeah.
And the more facilitatory is, I'm going to keep coming back to it, the less the inhibition pathways can have an effect, and the more they become, for want of a better term, atrophied.
Yes, right, yeah, for sure.
Or disused.
Yeah. So everything's trainable, isn't it? I think Dan Siegel is one of the guys that I like to listen to and read his books a bit, and he was saying that the brain is quite an extraordinary organ because it can grow itself by thinking, essentially. So by the way you use the brain, it will grow itself. But it's very much like a muscle, obviously. But it's when I guess in the way we see the brain, we see it as our tool of thinking and our tool of mind. But what Dan and his group do is they spent years and years, and so this is like a think tank of psychiatrists, psychologists, sociologists, anthropologists, and so on, trying to understand what mind actually is. And because he was already, as an author and a speaker, he had already been traveling the world speaking to large audiences, and he would always do a test to ask, because of course these audiences were largely from the psychological sector or counselling sectors. And so he would say, you've all been through professional training about the mind. How many of you actually given a definition of what mind is? And he said, you know, across sort of 10, 15 years of doing this, less than 5% of people worldwide, and this was over 100,000 psychology professionals that he had asked, less than 5% of them were actually ever given a definition of mind. And so, you know, what he came up with his group of, like I say, interdisciplinary group, they said that mind is the embodied and relational flow of energy and information. And I think the kind of field that we're entering into in manual therapies and understanding pain, that definition fits very beautifully with a lot of what we're seeing. That, you know, mind isn't in the head. It's not something that is like a hard drive in a computer, but it's the embodied and relational flow of energy and information. And so, you know, that suggests to us
Up and down.
Yes, exactly. That it can be held. We can hold tensions in the body as a result of experiences that we've had, emotions that we're holding, and so on.
Well, patients who don't relax is a good example.
Yes, exactly. Yeah. So I forgot what it was that triggered me to talk about Dan Siegel, but anyway, maybe I'll come back to that if it comes back to me.
Sorry, I've probably interrupted too many times.
No, that's fine. So look, one of the things that I've been aware of, and it's partly through listening to Jordan Peterson online, is that one of the things that can provide a lot of relief from anxiety, especially the kind of existential angst that we were talking about, is psilocybin doses, which is, of course, the sort of magic mushroom, as it's known colloquially, which is technically described as a hallucinogen. But I think more, in sort of shamanic and neo-shamanism type circles, it's often termed an entheogen, which means that it's a god-evoking, I guess in inverted commas, like loosely speaking, a god-evoking substance. And so the experience that many people will report on, and again, this is not too left of field, because these are clinical studies that have, I mean, they're fairly recent, the last 20 years or so, because I think it was a very taboo field since the kind of swinging 60s, and when these kind of more hallucinogenic compounds became listed as Class A drugs. So there was a block of maybe 30 years or so where there was very, very little medical research into. But as of the late 90s, there was a real sort of reblooming, if you like, of the research interest in psychedelics. And psilocybin, being obviously a naturally occurring one, has been studied by a number of different people. But what Jordan Peterson was saying about it was that it reduces the depression and anxiety associated with being in a terminal state. Many statistical points more than any other.
Yeah, I've seen some sort of evidence of that, actually, but not myself, but in research.
Yeah. And have you got any thoughts around that, where that could come from? Because of course we would, I think the standard narrative would be that hallucinogen is it's kind of like dreaming. You just make up stuff in your head, and you would think then, if that were the case, if you're facing death, you would think that actually you could have what might be termed a bad trip, right? A really bad trip, because it's altering your mind state and you're in a very anxious state already. Yeah. Let me just read this off to you. So this was an initial study that a guy, let me see if I can find his name, Roland Griffiths, did. He's a clinical pharmacologist. And he said 80% of patients with life-threatening cancer were given laboratory synthesized psilocybin in a carefully monitored setting in conjunction with limited psychological counseling. More than 3/4 reported significant relief from depression and anxiety, improvements that remained during a follow-up survey conducted 6 months after taking the compound. And he says this is simply unprecedented in psychiatry, that a single dose of a medicine produces these kinds of dramatic and enduring results. So
Yeah,
It's very
and I've seen a similar thing. I think it was on. I think the results were shown on. Mike Mosley did something
right,
about that. I think it was Mike Mosley,
right.
and but the study stopped,
Okay.
and they weren't allowed to give any more. So the depression came back in a lot of these people months later, and they're not allowed to go back on the medication again.
Right. So is
But it did have profound effects. You're right.
Mike
Yeah.
Mosley's no relation to Laura?
But that's about as much as I know. I can't. What mechanisms it works on is as good. I wouldn't even hazard a guess.
Yeah, exactly. Yeah. Well, one of the things that I've seen written about psilocybin specifically, but also some of the other hallucinogens, is that when these things are assessed using a functional magnetic resonance imaging approach, what you find is that, quite contrary to what you'd expect, again, you'd expect to see the whole sort of visual cortex light up. You'd think that if you're having all of these hallucinations, that you would be seeing all kinds of imagery, and the whole thing would light up. But what it seems to do, it actually seems to inhibit brain function. So you get much less activity during hallucinogenic experiences. So,
well, I suppose if it's dreamlike, then your brainwave patterns would be far less intense.
Yeah, maybe. One of the theories that I heard put out around that was that maybe if we were to invert the way we look at these things, which is the idea that the hallucinogen is generating imagery. If we were to invert it and say, well, the imagery is there, but normally we're inhibiting it through our normal brain function. So when the brain's active, it inhibits an aspect of reality that we can see. When we inhibit the brain using something like a hallucinogen, then suddenly we're exposed to other parts of reality. Yeah. And this is why people, of course, it's very controversial. So I'm not saying this is what's going on. I'm just saying this is one theory on it. But it's a very interesting theory because, of course, what most of these people found that had been through these psilocybin experiences, even though they had less than 6 months to live, was that their existential anxiety reduced, but they're also comforting all of their own relatives to say it's all fine, it's all going to be okay, it's not a problem. So
it's probably because they found peace.
Yeah, it could well be. And I did see something else about how the one mechanism of, actually, I think it was LSD, which has a similar effect, but it seems to almost inhibit the parts of the brain that are associated with ego formation. And or not ego formation, but a sense of self, I suppose, is a more technical term. So if you lose your sense of self, then you are much more, your conscious experience is that you're actually a part of everything, as opposed to being an individuated component.
Yeah.
So I think that may well be
outward looking.
Yeah, fascinating stuff.
It is.
So I think just to round off, we've touched on some of your PhD work, and we've sort of explored around that field a little bit. I know more recently you've done a bit of work with virtual reality, and you did touch on that. But is there anything specific from that recent work that you've done that you'd like to share or be interesting for?
Well, we're still finishing the research at the moment. We're looking at, because it's still very much in its infancy, of course, but we're just looking at simple distraction.
Yeah.
And we're using spinal cord injury patients with pain at and below level of the lesion. So essentially phantom pain.
Right.
In a limb that shouldn't have any sensation.
Okay.
So what we're doing is we're doing an immersive virtual reality application, and they have the same application as a control on a laptop screen. And although I can't talk too much about the results,
sure,
what we can say is that the pain relief with the immersive headset is quite profound.
Right. Wow. And
to the point now where we've got a grant the next year going to do the same with cancer pain.
Right. And does this relate to the rubber hand type experiments? It's more immersive than having a rubber hand. Is it?
Yeah, it's more immersive. Yeah. So they're completely surrounded by a 360-degree scene that they can wander around with a hand control. So all of the spinal cord injury guys, they're all C6, 7, and below, because they've got to be able to manipulate the
Yeah, right,
handset.
of course, yeah.
But really, and then at the same time they've got an EEG cap, and we're measuring brain waves and what parts of the brain where the brain waves change in frequency are related to the pain relief, etc.
Yeah.
And that I don't know yet, because we have another person, a researcher who's the EEG genius, and they're doing all of the analysis.
Right. Wow, fantastic.
So we're nearly finished that study. That study should be. We've got about 2 or 3 more participants to get through, and then we've already started writing up the article.
Fantastic.
But it's still very much in its infancy. And the other thing, of course, that's coming on from that is augmented reality. So you talk about hallucinations. You could actually manufacture these hallucinations in augmented reality glasses.
Right. Yeah.
Which is the next step, really. So they can go around their normal day with these glasses on and see a brighter life, if you like.
It's a bit scary in a way, isn't it? But kind of cool.
Well, augmented reality is used now in surgical training, where they put these glasses on and they open up a person, and the glasses differentiate different tissues into different colors.
Wow.
For example.
Wow, that's awesome! Really amazing.
It is. It's fantastic. Yeah. It's so awesome you could swear at it.
Yeah. So let's just sort of finish off by going into, as you're aware, the podcast is called From Chaos to Order, and I think we've talked about. I guess the title's a little bit tongue in cheek. I'm not saying that there's complete chaos out there, but there is so much kind of information for us as clinicians and people working with clients.
It's confusing.
Yeah. So how have you made sense of that kind of chaos or confusion in your own clinical practice? You mentioned you work with other professionals. I guess that's one way to help.
Mm-hmm. Well, I think, I mean, I know it's quite demoralizing to say, but it's been a hell of a long journey from first stepping foot in that master's degree and working with and studying with a whole host of different sort of medical doctors and psychologists, psychiatrists, and I've become immersed since 2007, and it's been a really long, often frustrating, but quite a fruitful and rewarding journey. And it's only now, after all that I'm able to talk like I am to you with some confidence.
Right.
But it takes it's hard work to get on top of what we've just been talking about, I think.
Yeah.
It's not rocket science, but it's just a lot of information. And how you process it as a practitioner, and how you simplify it for yourself, and then simplify it further for the patient.
Sure.
For example, writing that book, the most difficult bit was dumbing it down from really technical neuroscientific speak to manual therapy speak.
Right. Yes. Exactly.
That was the hardest part about that book, was condensing it all.
Yeah.
So that's what I mean. I would say you've got to be you as a clinician have to be immersed in the devil of the detail, if you like.
Yes, exactly. Okay. And so, what would you say to someone who, if you were talking to someone who's just about to graduate, and they were asking you for career advice, would you say follow the same kind of path I've done?
It's not for everyone. People, I would never dreamed in a million years I'd be doing research. I was quite happy sitting in my clinic. I would, the first thing I would say would be find a mentor.
Yeah. Great advice.
And find a mentor that you relate to. So it may not be research. It may be biodynamic or whatever. But something that's going to, improve you as a person and as a practitioner, and as a listener, I would say.
Yeah. Excellent. Well, I think we've probably we've covered most of the areas that we wanted to cover.
Yeah.
Is there anything else you wanted to throw in? Any particular sort of gems or snippets of things that you found really useful working with clients with persistent pain, or just sort of run of the mill clients?
funny enough, I still enjoy the run-of-the-mill clients most of all. The subacute low back pain, neck pain. They're the ones you get the best success with, and they're the ones that give you the most joy. But from a intellectual perspective, definitely the chronic pain patients, the really puzzling patients, the ones you've really got to do you've really got to go to the databases and study the presentation, if you like, and the comorbidities that go along with the presentations. I find them equally as rewarding, but I think you can't leave any stone unturned, and get yourself a set of 4 or 5 good, validated, strong questionnaires that you can use with the patients. So no more than 4 or 5, because you don't want to exhaust the patients. They'll just switch off when you give them too many questionnaires. You have to give them something that's really succinct and something that opens their eyes as well.
Right, yeah, for sure. And have you got any specific resources that you would point to there? Is there a specific site, or have you got?
Well, so I would download. I would get a hold of the pain catastrophizing scale.
Yeah.
The pain self-efficacy scale. So that measures your ability or your confidence in your ability to do stuff while you're in pain. That's another cognitive. Pain-related questionnaire. The DAS-21 is what we use here. That's a stress, anxiety, depression questionnaire. That's only 21 items, of course, and that's pretty useful. What else do we use? The facet I talked about, if you want to get a bit more existential.
Yeah.
And I think that would cover it, to be honest.
Okay, fantastic.
As a basic set of questionnaires.
Yeah, perfect. And how about so you're developing a questionnaire for central sensitization, which is the big challenge at the minute. Is there anything on that front? I know there's central sensitization.
We've had a couple of posters at International Association for the Study of Pain. We had a poster there, and we actually won Best Poster Prize at the Australia-New Zealand Pain Society scientific meeting last year.
Oh, great. Well,
so the interest for the questionnaire is there. We've just got to get past the bureaucracy, if you like.
Yeah, no, fair enough.
And when it's published, hopefully it'll be called the Pain Modulation Index.
Okay. So one to look out for.
Yes, hopefully. Fingers crossed.
Yeah. Excellent. Good stuff. Well, that's brilliant. Thanks so much for your time today and for doing the work that you're doing. It's
a pleasure. It's been interesting.
It's really fascinating, and I think really important for us as as manual therapists, as healthcare practitioners, even fitness professionals, to understand these kinds of things. If people wanted to get hold of your work, I know I've got your book here, so that's Chronic Pain: A Resource for Effective Manual Therapy. Great book, actually. Yeah. I've not read it, obviously, cover to cover yet, but
it's not a cover to cover book. It's a book you go to when you have a question you need to answer.
Sure.
Hopefully.
Yeah.
It's a reference book.
Yeah. Do you have? I know you've got a number of papers available online, but do you have other resources or courses that you run, anything like that? Where people can get hold of you?
The trouble is with pain is I'm often the purveyor of the inconvenient truth.
Yes.
Where I don't give them the $64,000 technique that's going to make them a lot of money.
Yeah.
And because of that, I've decided that I don't set myself up as a pain course person.
Yeah, fair enough.
Only because I've seen lots of other people try and fail.
Right. Yeah.
So what I do is I more speak at manual therapy, osteopath type conferences.
Mm-hmm. And
I talk about the same thing I've been talking with you, and it's a better way of putting it across.
Yeah, excellent. And do you accept patients as well? If someone's got a patient that they happen to be nearby to you, and or not even if they are nearby, maybe people fly in to see you. But is that something you're actively?
Yeah, people do. Yeah. I mean, they might only be in town for a day or so, and they come in. Yeah, I mean, it doesn't happen very often, but it does happen. A few times every 6 months, I would say.
Brilliant. So, how can they find you?
Address-wise?
Yeah, well, I guess, to look you up, they just look up Phil Austin on Google.
Oh, well, it's St. Luke's Clinic in Sydney.
Excellent. Okay, perfect. All right, well, what I'll do is I'll put any relevant links into the show notes, and then hopefully people can can track you down if they need you or want to learn more. Thanks so much again for today, Phil. And
No, it's been a pleasure. It's been interesting to talk to you.
Yeah, likewise. Yeah. Hopefully our paths will cross at some point. I'm out in hopefully, fingers crossed, out in Australia in March next year. So I don't know if you're going to be around, but if you are, hopefully we can grab a coffee or something.
Yeah, I think. Aren't you in contact with Jonathan Payne?
That's right. Yep. And so
yes. So he told me. Yeah, that's right. Yeah.
Perfect.
Yeah, hopefully in March then.
Yeah, that would be awesome. All right. Well, take care till then, and
all right,
thanks again.
Yeah, wonderful. I'm looking forward.
Bye-bye.
Thanks again. Bye-bye.
Thank you for listening to this episode with osteopath and postdoctorate researcher Phil Austin here on FC2O. If you enjoyed that and found it useful, please feel free to share it with your friends, colleagues and loved ones. To learn more about Phil's work, please head over to osteopathy-chronicpain.com. That's osteopathy-chronicpain.com. And for those of you in Australia and New Zealand, I'll be heading out your way next March 2020 to put on a 2-day presentation and workshop, one in Auckland and one in Sydney, called 2020 Vision, Putting Persistent Pain Behind Us in the Next Decade. Details are available on mattwalden.com. Finally, ensure you catch our future episodes by subscribing at Apple Podcasts or following us on Spotify or Stitcher. Looking forward to having you join us on the next show.